welcome. This is Stephen Bailey, CCI Editor-in-Chief with a CCI cast. And today we have a great opportunity to talk about two important areas that have significant overlap. And to have this discussion, we're excited to have Odayme Quesada, who is the director of the Women's Heart Center at Christ Hospital, and her colleague, boss, who's hired her twice, we learned, Tim Henry, who everybody will recognize from his roles as an investigator, as well as president of SCI. But Tim is the Lindner Family Distinguished Chair in Clinical Research and Medical Director of the Carl and Edith Lindner Center for Research at Christ Hospital. And of course, we're joined by Mirvat Alasnag, who really is the person who makes this happen. We're going to look forward to a great discussion, and perhaps we could have Odayme and Tim sort of do an overview of the manuscripts that were published, now articles, and your view of why they're so important today in this arena.
Thank you so much. We were honored to be able to write this manuscript on how to develop a women's heart center with specialization in a coronary microvascular and vasomotor dysfunction. If you build it, they will come. Essentially, the thought behind this is that women's heart centers are becoming increasingly important in the United States and throughout the country to be able to develop specialized care for women. And we decided to build our particular program center around coronary microvascular and vasomotor dysfunction program. And essentially what we had the opportunity to do was say how we did this. How were we able to build a very successful and fast growing program? And essentially what we did is we centered it around some fundamental pillars that we go over in the manuscript. First of all, clinical care. So we created a specialized program of coronary microvascular and vasomotor dysfunction, where we are the experts in the field in the tri-state region, and therefore we get referrals from all the centers around us to do specialized testing, which Dr. Henry is going to speak more about, the functional invasive testing that's needed as part of this program. But we were also able to do a center around other pillars like education. That was a key thing for us because we were really focused on increasing awareness about ANOCA, angina with non-obstructive disease, and the importance of diagnosing coronary microvascular and vasomotor dysfunction in these patients. And that took education on multiple pillars, from the provider level to essentially staff, and be able to educate even other providers in other specialties like emergency medicine, internal medicine, primary care, to appropriately, in addition to cardiology. Yeah, and then the other important piece in addition to education was research. We really focus our coronary microvascular and dysfunction program on the pillar of research. Essentially, because of such a creating the program this way, we were able to draw in multiple research studies specifically in this area, which has allowed our program to grow. And then last but not least, community outreach and grants and philanthropy to again bolster our research and our education efforts in the community. So those were the pillars in which we developed our program. And in this document, we're able to go through each of those pillars and how it is that we developed our current program.
And the second part of the article is what to do in the cath lab. And I think we know that non-obstructive disease, chest pain, ANOCA, INOCA, and MINOCA are underdiagnosed and undertreated. And one of the problems has been, number one, lack of testing, lack of familiarity with testing. And I think one of the key parts of these two is that it's not just doing the test and making a diagnosis, it's really having the infrastructure to take care of those patients. And, we know that the average person that, has been shown with ANOCA or ICA has had chest pain for 5 to 10 years, has seen 3 different cardiologists, has had 3 to 4 angiograms or CT angiograms, and has had more than 5 stress tests. And what they don't have is a diagnosis. So number one, we start the testing, and we have used both Doppler and thermodilution, and actually soon we'll be doing continuous. So the ability to do that with invasive testing as well as MRI and CT from non-invasive testing, I think is an important part of that. And we outline how we use standardized protocols in both cases to answer specific questions.
So I know that you're focusing a lot of this on women and who often, have underdiagnosed or undiagnosed chest pain. But Tim, there's a lot of men as well. I mean, this is a very large group. And I know that you've been very interested in this particular arena, chest pain, otherwise, not treated, underdiagnosed. Um, how do you see this globally fitting before we
Yeah.
narrow it a little bit?
So that's a great question, Steve. And I will tell you, we need to take a bigger picture. So for many out there know that I've been interested in refractory angina for a long time. And non-obstructive disease is really a form of refractory angina. And the other, I think, really key point for people out there is we like to put people in different groups like obstructive disease, microvascular disease, vasoconstrictive disease. But many times, I'll tell you, it frequently overlaps. Many people have aspects of all three. So we have to really say, why are you having chest pain? And that can be obstructive, microvascular disease, or vasoconstrictive. And it's really important. And there's no question, there's a significant, 30 to 40% of the patients that we see are men.
So this really, in terms of who this is targeted towards, women is part of this, but it sounds like it's a much broader group that are availing themselves of this opportunity.
Yeah, and even though we built our coronary microvascular and vasomotor dysfunction program in the context of a women's heart center, because historically, ANOCA, angina with non-obstructive disease, or ischemia with non-obstructive disease, is a female predominant phenomenon. Our program is actually gender neutral. So we do recognize that this is something that's under-recognized, underdiagnosed in men and women. And so we have seen an increase in both. We've seen a very rapid increase in both the female and the male population with microvascular dysfunction, whether it's someone with non-obstructive disease or, as Dr. Henry's saying, patients with history of obstructive disease and many times no other options. That underlying microvascular dysfunction is the cause for their ongoing angina.
And I think another really important point, Mirvat and Steve, is that um, the microvasculature is critical in many things, not just chest pain. So I think in the next 10 years, this will be a major focus. For example, 75% of patients with HFpEF have microvascular dysfunction. 60% of anterior STEMIs have microvascular obstruction, and those are the patients who do poorly. 30% of people with successful PCI and successful CTO PCI still have chest pain. And it's also recurrent Takotsubo, HCM, other cardiomyopathies. So this is, I think, a really broad area, and understanding the microvasculature and how to test for it is critically important.
We
So
see young patients in our part of the world, particularly diabetics and smokers. And we always think of it in the setting of epicardial coronary obstruction. But a lot of them are the ones that have combined epicardial obstruction with microvascular dysfunction. And I know your second paper looked at algorithms on how to approach these patients. Perhaps if you can walk us through these algorithms so that we can just get a little more familiar with what we should be doing in our labs.
Yeah, that's another really important question. So what we did, Mirvat, was first of all, there's still around the world a lot of different ways people do the testing. And what we wanted to do was at least be consistent so that we could learn from it. So when we did Doppler, we actually, as part of the WISE trial, we patterned after the WISE trial. We actually hold everyone's drugs for 2 days. And then we would do Doppler with adenosine, intracoronary adenosine in the proximal circ, then the proximal LED, then the distal LED. Then we would give mid-dose and high-dose acetylcholine, and then we would give IC nitroglycerin. And then following the IC nitroglycerin, we would repeat the coronary flow reserve in the proximal LED. This allows you to know if you have endothelial dependent or endothelial independent microvascular dysfunction. It allows you to know if you have epicardial coronary artery vasospasm as well as microvascular spasm. And specifically that protocol is designed to say, what's the difference between the proximal LED and the proximal circ? what's the difference between the proximal and distal LAD, and what's the difference pre and post nitro. With thermodilution, and we have about 300 patients that had Doppler, and now we have about 300 that have thermodilution, and we've changed that a little bit. We're again looking at location, but we're also looking at IV adenosine versus IC adenosine. So our goal is to not just take care of people and get a good diagnosis, but it's also to hopefully answer some important questions.
Yeah, and to add to that, the other part of the question is also who do we send for invasive functional testing? Because the reality is that we can't, at least in our center where we're very high volume, we have over 3,000 patients, majority of which are ANOCA patients or patients with refractory angina with a history of obstructive disease but open arteries. So the question is, who do we send to invasive testing? So essentially the algorithm that we showed is what we do clinically, which is if there are patients that have predominantly class 1, class 2 symptoms, those are patients that we start with non-invasive testing. So we leverage stress SPECT, we leverage stress MRI, we have a very strong program here, and we try to determine a diagnosis that way. When you have patients that have mixed disease and more severe disease despite medical treatment, that means that they have exertional symptoms and rest symptoms. These are patients that we are sending for invasive functional testing, predominantly to determine do they have endothelial dysfunction, microvascular spasm, or epicardial spasm that we can only diagnose utilizing acetylcholine in the cath lab. And then we have patients that have a history of obstructive disease, and these patients tend to be a bit higher risk. So when they do present to us with ongoing symptoms, these patients, we often very early on think about invasive functional testing to determine endothelial dependent, independent, and then of course the spasms. So earlier on, if it's someone with a history of obstructive disease, well, we think about invasive functional testing to really determine which pathways are abnormal.
So Tim, what percentage of patients with your current algorithm are you able to arrive at a diagnosis for?
Yeah, so first thing I say to a patient is, Steve, is our goal today is to figure out why you have chest pain. And you've been dealing with this a long time, and so really our number one purpose today is to do that. So for example, we hold drugs for 2 days and vasoactive drugs for 2 days. Right now, I've done the majority femoral because we don't want to use vasoactive substances. Although, again, these are things that we're learning, and it may be that doing radial is just fine. And then what I also do from a standpoint of that is I don't use a lot of sedation because we lighter than most cases because we want to know when you're having chest pain. So both with adenosine and with acetylcholine. So we spend time with that. And I would say at the end of this, well, our data shows that about 90% of the patients that we do have a diagnosis, have a cardiovascular diagnosis for their chest pain. 10% are non-cardiac. Well, that's helpful too, because number one, it keeps this, as you know, these patients come to the emergency room, they keep getting testing. And so if you know a diagnosis, that makes a big difference. And then I would say, once we know a diagnosis, we know from the Carmichael trial that having a diagnosis helps you do better treatment. Now, this should be obvious for all physicians, right? Knowing what your treatment helps, knowing what you are treating helps you treat it. And then we can actually target, I think, really specific things. So people with severe epicardial spasm might end up on 2 calcium channel blockers, an IMDUR, et cetera. But we know what we're treating.
Yeah, and that was the question I was going to ask Odayme, because she's seeing these patients come back after you have established the diagnosis. And, I know in your manuscript talking about the clinic, you also talked about how to approach therapy.
Yes.
So maybe you could just talk a little bit about, what the findings are that would influence specific therapies.
Absolutely. So when we see that a patient has endothelial independent microvascular dysfunction, which is that CFR abnormality in response to adenosine, we will put all of these patients on statin and ACE-ARB inhibitors for improvement of their underlying disease process. There's small studies showing improvement in coronary flow reserve with these therapies. And then in terms of antianginals, our first line antianginals is a beta blocker for these patients, followed by a calcium channel blocker. And then our third line is Ranexa. If we have endothelial-dependent dysfunction, it looks a bit similar, except the first-line antiangiogenic is a calcium channel blocker. Whereas when we have epicardiospasm or microvascular spasm, we start with a calcium channel blocker, we move on to a nitrate, a long-acting nitrate, whether that's Imdur or a nitro patch. And then in some cases of severe spasm, we may have to utilize a second calcium channel blocker. So those are how we can maximize the information from our invasive testing to actually treat these patients based on their pathways. Some patients do have mixed pathways, so then it gets a little bit more tricky. But essentially, we take from both pathways to find the right cocktail.
So, what you're illustrating is the combination of the invasive assessment and whether or not there is one or multiple etiologies really can now be used for you in your clinic to really identify what that algorithm looks like. And I think that's the other thing that so many people have struggled with is without the diagnosis and understanding, what's going on, it's very difficult to find a treatment strategy that's likely to work.
And the reality is a lot of these patients have mixed symptoms. And from the symptoms alone, you can know what to prioritize. But for instance, if Dr. Henry does an invasive testing and this patient has severe epicardiospasm where we lose the coronary artery when we give acetylcholine, well, I'm going to prioritize that pathway. I'm going to prioritize those calcium channel blockers above anything else. And we do have patients that typically don't tolerate it. It takes a fourth, before they finally get the calcium channel blocker that works for them. If you didn't know that they had epicardiospasm, we wouldn't do that clinically. We try something clinically. If it improves their angina, great.
Well, now the last question, of course, is in today's world of GLP-1s, SGLT2s, where everything seems to be beneficial. From your database on the research side, can you tell us anything about that? Have you been investigating that? And if so, any early insights into that potential role as a treatment strategy?
Fabulous question. Thank you for asking that. So yeah, actually, we have leveraged the fact that we have a registry of all of our patients in our program. And what we actually found, and we just presented it at AHA, was if you take these ANOCA patients with CMD diagnosed invasively, and you look to see if they've been clinically treated with an SGLT2 inhibitor, we actually see that there's been a reduction in class 3-4 angina in the patients that have been treated clinically. Granted, these are patients either with diabetes or HFpEF, so that's the reason they were treated clinically. We are now actually doing a pilot study in patients with ANOCA and CMD without diabetes or HFpEF to see if we see similar results.
And Steve, well, maybe a final thing from this is one of the things that has held the field back is this nihilism that says, well, even if we know what the problem is, we can't treat it. But we disagree with that. We know that people that are in a specialized clinic like this, nearly 90% of the patients are better after the end of 1 year. And second of all, we have a lot of novel things, including we use EECP, we use the coronary sinus reducer. There are a number of new novel drugs that are coming. So I think that there will be many different options for this, but it really helps when you have a specific diagnosis so that you can use a homogeneous patient population to test whether something works or doesn't work.
Well, this is fabulous. The bookend for the articles, I think, was incredible because it was not only the diagnosis, as you eloquently described, Tim, but also the approach to educating the community, not just the physicians, but the entire community about the opportunity for this, looking carefully at those patients, having strategies that are built upon the pathophysiology. And I think you're right. I think that what you have done in these two manuscripts is really to advance the knowledge that we have. And I really believe that folks after looking at this, are going to want to be involved and do better care for their patients. We all want to do it. We just haven't had sort of that roadmap for it. And I think you've contributed to that. So thank you so very much for the manuscripts and so much for the discussion today. I know it's going to be well received. Mirvat?
Thank you very much. It was really refreshing. I know we're struggling in our lab, and I know other cath labs are struggling as well to get these kind of programs started. Partly because what we discussed today is we don't know if we are able to treat these patients, and it's nice to see the evidence that yes, we can actually help these patients, and a good number of them recover. And just to have protocols. I mean, it's obviously a lot more interesting to play with the toys in the cath lab, the stents and the impellas and so on. And this takes a little more cerebral work to do, but I think it's worthwhile.
It does. For one last comment, just these can be done, even though we did comprehensive testing, the average case takes only between 30 and 40 minutes. So you can actually do it very expediently when you do it, and do it systematically and still answer questions.
Good to know. Well, thank you again. Enjoyable conversation.